What's next in narcolepsy treatments? It's no secret that the prospect of novel narcolepsy treatment options gives hope to many people and families living with narcolepsy. In today's episode, I speak with Dr. Marie Morse to discuss current treatment options, what's on the horizon in drug development, and how people with narcolepsy can get involved to advance progress by participating in clinical trials. We also talk about non-pharmacological approaches like social support. Today's guest is Dr. Marie Morse, a board-certified and fellowship-trained pediatric neurologist specializing in sleep medicine at Geisinger Health System in Pennsylvania. Dr. Morse is certified by the American Board of Psychiatry and Neurology with special qualification in child neurology. Welcome to Project Sleep's podcast. Project Sleep is a 501c3 nonprofit organization dedicated to raising awareness and advocating for sleep health, sleep equity, and sleep disorders. I'm your host, Julie Flygar. We're so glad you're here as we work together towards making sleep cool. On this podcast, all guests express their own opinions. While medical diagnoses and treatment options are discussed for educational purposes, this information should not be taken as medical advice. Each person's experience is so unique, which is why it's so important to always consult your own medical team when making decisions about your own health. If you haven't done so yet, please hit the subscribe button so you never miss a Project Sleep podcast episode. And if you enjoy this podcast, please leave us a rating or review wherever you listen so that we can reach more listeners and raise more awareness. The Narcolepsy Nerd Alert series invites listeners to dive deeper into specific topics relevant to living with narcolepsy. For more on this topic, please check out our corresponding toolkit, available for free on our website to download, print, and share. The link to the toolkit and other Narcolepsy Nerd Alert topics is in the show notes, or you can go to project-sleep.com. Hello, welcome everybody. We're really excited to talk about new and upcoming narcolepsy treatments today. We have a very special guest with us today, Dr. Marie Morse. Hi, Marie.
Hi, how are you? Thank you so much for having me today. I'm super excited to be here. I feel like I reached celebrity status by being on the Narcolepsy Nerd Alert. I'm very, very impressed with everything that Project Sleep has done. But this, I think, has been a highlight and just really pleased to have the opportunity to be here with you today.
Well, we're so excited that you're with us. I think you're definitely probably a little bit of a nerd.
Yes.
Yay. So Marie, pediatric neurologist and sleep specialist, and you're at Geisinger. So that's like central Pennsylvania?
Yes, it is. It's right smack in the middle. We cover 47 counties in Pennsylvania. So Jadaweiss Children's Hospital is our children's hospital and Geisinger is our larger healthcare system.
Okay. And how long? So you just said that you think that we've known each other now for 7 years?
Six years. 6 years. I believe we met in 2015 at the Sleep Research Network meeting, which was a PCORI sponsored meeting. And that was a period of time where you were sharing your passion already about narcolepsy and how to advocate for the patient and empower the patient in their journey. And I was just a fellow under Dr. Michael Thorpe at that time, where I was just becoming enamored with learning more about narcolepsy and the journey that patients are experiencing. So that is definitely when we first got together.
Yeah. Oh, so cool. All right. So for today, we're going to do an overview of treatment approaches, and then we're going to talk about current medications and then new and upcoming medications, and then also some non-pharmacological approaches. So at Project Sleep, we really talk about these 4 pillars of narcolepsy treatment, and that's why I'm so excited. I think medications are so super important and absolutely a foundational part of many people's treatment with narcolepsy. But we can't forget about some of the other coping mechanisms and strategies that can be extremely helpful as well. And so I include those things are naps, social support, and lifestyle adjustments. So we'll get to some of those as well today, hopefully. But we will start with medications. Marie, can you help break this down?
Sure. So when we're talking about current medication options, it is going to depend on whether the patient is pediatric aged or adult aged. I'm going to talk about it more globally and really focus a little bit more so on the adult population because I think it allows us to have more of a broad spectrum. When you look at the American Academy of Sleep Medicine's recommendations on this is how you should take the approach to treatment of narcolepsy, there frequently is different tiers of approach. And many times we're talking about alerting agents, we're talking about oxybate therapies, and then we're talking about traditional stimulants, and then some other cataplectic agents. So when you're talking about alerting agents, the ones that I think historically have been known the most are your modafinil or armodafinil. There's newer kids on the block with pitolisant and solriamfetol. When you're looking at modafinil and armodafinil, and even solriamfetol, they all have shared mechanisms by really working on your dopamine in your brain. And dopamine is a neurotransmitter that helps in maintaining wakefulness and really having that alerting effect. These are a little bit different from your traditional stimulants because they're more centrally acting. What that means is you're less likely to experience some of those side effects like heart palpitations or appetite suppression or increase in blood pressure. Although those can still happen, they're less likely to occur. Alerting agents are ones that are definitely considered first line therapies. One of the other ones that's a new kid on the block is that pitolisant, which I just mentioned, but it has a very novel mechanism of action. It works on your histaminergic system to enhance your wakefulness. It also has been found to be effective in treating cataplexy events. What is really important about this particular treatment is also a non controlled substance, where most of the treatments that we're utilizing to treat excessive daytime sleepiness are controlled substances. When we go to the next types of therapies, which are also considered another first line therapy, meaning that if you have narcolepsy, these are ones that your doctor may be offering you right off the bat. It's your oxybate therapies, sodium oxybate and low sodium oxybate. The reality is sodium oxybate has been available for a long period of time, but it had a very high sodium concentration in it, about 1600 milligrams in a 9-gram dose that would be taken at night. The low sodium oxybate has a much lower amount of sodium in it, only about 131 milligrams in that same 9-gram dose, which is the reason why that is another option that has been available to help in navigating some of that sodium concentration. This is a medication that you're going to take at night, which is going to help in sustaining your ability to fall asleep. And the result of that is going to result in improved excessive daytime sleepiness. And we also see significant improvements in cataplexy events. Now, when you go into your second and third line therapies, you're looking at methylphenidates and amphetamines. These are your traditional stimulants that most people are familiar with in terms of ADHD treatments. So when you think of things like Ritalin, for example, that would be considered a methylphenidate class, or Adderall, that would be considered an amphetamine. Methylphenidates are considered second line, and amphetamines are considered third line. Again, they also are working on your dopaminergic system, but tend to have more systemic effects. And many times people can experience more of that heart palpitation and some of those undesirable side effects. Finally, when you look at your antidepressant medications, these are being used specifically for anti-cataplexy. And the reason why is because we recognize that when we are adjusting a person's norepinephrine in their body, it helps in reducing the likelihood of experiencing cataplexy. One of the particular points I always like to call out about the antidepressants is that we sometimes will utilize them for a dual benefit. We recognize 30 to 40% of individuals who have narcolepsy may also have comorbid psychiatric concerns such as depression or anxiety. And so sometimes we'll utilize these for the intention of treating that comorbid psychiatric piece. And the added benefit is that you may see that there's improvement of some of these others. One of the things I do like to call out, because the fact that's a rate limiting step for patients' treatments, is that sometimes insurances will say you need to fail one of these medications before trying an oxybate therapy or something like pitolisant. The reality is that pitolisant oxybate therapies are considered first line therapies. Antidepressants are considered options but have no FDA indication for the treatment of cataplexy. And therefore, those should be utilized and offered first before considering any of the antidepressants.
Oh, thank you for such a good overview. It's exciting to see that there are some new kids on the block in this area, because for a while we didn't have any new kids on the block. It's probably since the early 2000s. I guess at one point I'd really like to just mention, because a lot of these are alerting agents or stimulants, and something that took me many, many years to figure out was just what anxiety is. I had heard that some of these different medications can cause anxiety. And for me, I thought of panic attacks. And I had a friend that had panic attacks in college. I thought that was anxiety. And it was only in a support group, many years into my diagnosis, where someone described their anxiety as like this black cloud of darkness kind of like over them, and like nothing can be funny. And they just have this negativity that's not based in their sense of reality. And I just thought that was so powerful. And I guess just wanted to mention it at some point today because I'm just afraid that other people might not know about some of the common, I don't think we talk about some of the common side effects for some of these medications. I had that both with modafinil and I've had it with stimulants, but side effects are a part of it. And obviously complications too, when people can't take certain medications because they have complications of other conditions, that gets really, really tricky really quickly too, I bet.
100%. And I think you're right. I think a lot of people don't recognize anxiety. And I think one of the challenges when you're talking about individuals who are experiencing their journey with narcolepsy is that anxiety creeps into their life without them being aware of it because there's all these other symptoms that have occurred. And so sometimes anxiety is truly another condition that is a part of their journey. And sometimes it's just a consequence of how long their journey has taken to getting to the right diagnosis. So they're constantly waiting for that other shoe to drop. I went and I saw the endocrine doctor because I thought it was a thyroid problem. I went and saw the infectious disease doctor because I thought it was Lyme or because I had mono. And so there's all this anxiety of, do people believe me? Am I going to be able to actually meet that deadline? And a lot of people start to absorb that as that's just a part of who I am. But you're right. There is that true anxiety that can be a part of the illness. But then there's also that anxiety that you're 100% correct can be a part of the experience of when a person is on a stimulant, because I might be more awake and more alert. I might be less able to control my emotional response to changes in my surroundings. So you're 100% correct. And I do think it's really important because a lot of people still have a challenge in acknowledging mental health concerns and feel ashamed of those things. I do think it's a really important call to attention to say that should be front and center because taking care of the whole person is critically important for any provider.
Yeah. Yeah. For me, I figured it out that it was the medication because of an error. And instead of getting the slow acting version, a pharmacy gave me the fast acting version of the same amount. And so for 2 days, it was hitting me so strongly that it was like, it took over my life. Like I couldn't leave my house. I was, so like there was this dark cloud of negativity. And it was only seeing anxiety in an extreme form that made me then realize some of the lesser forms for me, and to be careful about how much coffee I had too. If I had too much coffee in addition to stimulant, that could also bring it out. Is there anything else before we move on to upcoming treatments?
One of the things that you've mentioned in regards to the increased number of players that we have in terms of treatment is a reflection of just improving slowly but progressively improving awareness and investment in trying to create more treatment options and more knowledge about the disease process. So I think that because of those advancements in science and having a better understanding of the potential pathophysiology contributing or what is causing to developing narcolepsy, I think you're going to see a reflection of changes in treatment modalities available.
Yeah. And really quickly, before we get to that too, I think that you have pointed out the AASM's guidelines, and we do have that in the resources at the end, and we'll make sure. It seems not all sleep doctors are maybe aware of some of the best line treatments or familiar enough with them or feel comfortable enough. So I think that's important that patients become educated about what is considered frontline treatments, as you've discussed today. But we do have that guideline as well. And I don't know what you'd say, Dr. Morris, but if someone feels like they're maybe not getting access to frontline treatments because perhaps their doctor might not be as familiar with them, my advice would kind of be to consider getting a second opinion from another doctor or trying to find out who treats a lot of people with narcolepsy in your area and who feels comfortable with the different options that are available. But I don't know. That's just a concern of mine, is that some sleep doctors still aren't super familiar with all these options.
I think you're correct. And I think the challenge is that narcolepsy is technically considered a rare disease, correct? Even though my clinical experience would argue that it's not as rare as we potentially consider it to be. And what I would say is you're correct that different people have different levels of experience with the medications, different levels of experience with the disease, and therefore that might lead to discomfort. And you're 100% correct that most healthcare providers don't feel comfortable saying, I don't know, and that I'm uncomfortable, or you're the first patient who I'm going to be prescribing this medication to. I very frequently see that as a rate limiting step for providers changing their behaviors. But again, I think that's where, as a patient, it's really important to feel empowered and educated. I have found, whether I'm wearing my neurology hat or my sleep medicine hat, that when I'm talking about rare diseases, that it's not uncommon that my patients or the parents of my patients are far more expert than most providers. And so I would say that if you are meeting a provider who is intimidated by that, that also may be a sign that you do need a second opinion. And a second opinion doesn't mean that you don't like your doctor. It doesn't mean that you're going to necessarily have to change your doctor. It means that you are doing the scientific method, right? You have a hypothesis that you can do better. You're testing that hypothesis by seeking out an alternative treatment strategy. And then you're going to utilize that treatment strategy to see if that makes a difference, right? And so I think that it is very important, through the work that you guys do on a daily basis, to continue to educate and empower, and for patients to demand shared decision making with their providers. The days of old of the provider always being right and this is the only drug and I'm smarter than you, that is horrible. That is not the right way to care for patients. We need to take care of the full person in front of us and really understand what's important to them. Just because I may have 10 patients that did great with drug A doesn't mean that my patient 11 is going to have that same response. And so I need to hear from them as to what is their priorities, what is the experience that they're having, and what are their fears. And that is where we have to work together to be able to develop a treatment plan and then also respond to, how are we going to monitor your response to that? So I think that sometimes is a fear for providers to look like they chose the wrong drug, or that they're going to experience a side effect that they don't know how to navigate. And what I have found is that when I'm truthful with my patients and give anticipatory guidance of these are things that are possible, not necessarily expected, that patients have a trust in that communication and are willing to enter that journey with me being the guide on the side. No longer do I try to take that role of being the director or the captain of the ship. They're the captain of the ship. I'm the guide on the side that really is just helping with the navigation and giving all the options that I think may be helpful to them. But I always love when patients come to me and say, I saw that there was this new treatment. A lot of people will tell you, don't go to Dr. Google. I think it's a matter of, if you go to Dr. Google, have the opportunity in the communication capacity to speak with your doctor of, this is what I've read. Can you tell me whether this is true or false? Can you tell me what your experience has been with it? And then be able to make those communications together.
Such a great point, especially as there are new treatments available coming to market. There's going to be more options, so more to talk about. So walk us through the exciting things of what's coming in the future, because this truly is so much hope for so many people.
I agree with you. So when we're looking at the different treatment options available, I would say that what we have here is first we have FT218. This is a once nightly oxybate therapy that has completed its phase 3 trial, currently is going through open label extension. What that means is that patients who had previously been in a trial are able to continue taking that medication, and then it may also be available to other people who had similar medications and wanted to transition to them. Now, we had talked about that there is oxybate therapy currently available, but that oxybate therapy that's currently available, both the sodium and low sodium oxybate, is twice nightly. You take one dose at bedtime, and 2.5 to 4 hours later, you take a second dose. For many patients, that's fine. They do great. But one of the conveniences that many patients will describe is that they would really prefer to be able to take one medication versus having to take it multiple times. So this is a once nightly sodium oxybate that is waiting for FDA approval to be able to become something that is clinically available. And so this is, again, something that is going to be taken at nighttime and does treat excessive daytime sleepiness and cataplexy. Now, when we're looking at the next treatments, the TAC-925, the TAC-861, and the TAC-994, the TAC is just standing for the name of the pharmaceutical company, which is Takeda. They are all orexin agonists. And so what is orexin and why is that relevant? Well, when you're talking about orexin, or also known as hypocretin, it's the neurotransmitter or the brain signaler that many patients who have narcolepsy are deficient in. So people who have narcolepsy type 1 or narcolepsy with cataplexy have low levels of this neurotransmitter, which is responsible for the symptoms that they're experiencing. And the reason I specifically say that is because with narcolepsy type 2, they tend to have normal levels of this. And so we don't fully understand the mechanism that is occurring for patients who are narcolepsy without cataplexy or narcolepsy type 2. And we're looking at, what if we give people this neurotransmitter back? What if we allow them to have this self signaling capability back by giving them this replacement? And so these are all very early phase studies. And so when you're looking at the TAC 925, this is an IV formulation of that medication. When you're looking at 861, this is oral, and so is the 994. The unfortunate news about the 994 is that that clinical trial has been stopped due to a concern of a safety signal. However, just because that trial has stopped does not mean that the 925 and the 861 may not come to fruition as being a treatment option that will be available for patients in the future. These are all in early phase studies, so phase 1 and phase 2 studies, which means that they're really looking at the safety, the tolerability, and the appropriate dosing. And before they go into the more advanced studies to do randomized control to say this is the effect that we are seeing consistently in order to get that FDA approval. When you're looking at the SUVN G3031, which is samloxane, this is a histamine medication as well. This is working on that histaminergic system. So this is similar to the medication that we already see that is approved, which is pitolisant. And this is in phase 2 trials right now. AXS-12 is reboxetine. This is a norepinephrine reuptake inhibitor. Now, remember on the last slide, I had described to you that antidepressants are frequently used because it affects your norepinephrine. This is a medication that is being studied to specifically be a treatment for cataplexy alone. If you recall, none of those treatments that I described have an FDA approval. So this is a company that is doing their due diligence to say, we not only want a treatment that is a norepinephrine affecting medication, but we want to make sure that we are getting you to dosing and the titrations and the safety and getting that FDA approval, which only makes it easier on the physician or the provider side to get these drugs approved for treatment. THN 102 is actually a combination medication. So it's a combination of modafinil plus another medication called flecainide. So flecainide historically is a medication that is utilized clinically in cardiology as a arrhythmia problem, okay? So trying to help people with cardiac rhythm problems. And so many of you sitting here or listening to this may go, well, then what's the relevance to narcolepsy? Well, the reality is the relevance to narcolepsy is that when studied, they actually have found that it can affect what we call astroglial connexins. And so basically what this is something that is very much involved in kind of sleep regulation. And what they're identifying is that by affecting this, not only may it augment or increase the ability to have better sleep regulation and further enhance that modafinil's effect on alerting, but they also have identified that there may be some secondary gains in cognitive performance. So one of the things that many patients may describe to me is that they feel like they have brain fog. No matter how well I treat their sleepiness, even though I do the Epworth and I ask them about, are you falling asleep in this place, that place, et cetera? Do you feel like you're dozing? Do you feel like you can do all the things you want to? They may say yes. They may still experience this inability to feel like they're processing the same way and focusing the same way and really have a concern about their cognitive performance. And so what this drug is really looking to do is potentially say, not only can we keep you awake, but we can optimize your cognitive performance. The final medication is one that is a very old drug, clarithromycin, and it actually is an antibiotic. It's one that has been used very commonly, and most commonly, actually, I've seen it coming out of Emory from really incredible sleep scientists down there in the use in idiopathic hypersomnia. And they also now are extending this to the use in narcolepsy. And the reason that they're using this antibiotic is not because people with narcolepsy have some unrecognized infection, but because of the fact that one of the other things that are occurring is that they identify that this clarithromycin may have some impact on our GABA system, so our inhibitory neurotransmitters. And so with that, they're identifying that when they're giving this medication to individuals with central disorders of hypersomnolence, such as narcolepsy or idiopathic hypersomnia, that they are seeing an alerting reaction to it. And so that is currently in phase 2. So a lot of these studies are in early stage research, so phase 1 or phase 2. Phase 1 is typically looking at, again, that safety signal, that tolerability. And usually that's not even in individuals who have the actual disease state. It may be in healthy volunteers. It's in phase 2 and phase 3 where we really start to look at individuals who actually have the disease. So in this particular case, narcolepsy, we then identify what is the best dose that gives them tolerability without any side effects, and how is their body metabolizing it, and what is the best dosing and timing. And then the phase 3 is usually saying, not only do we know the dose, not only do we know the side effect profile, but we are demonstrating that there's improvement in excessive daytime sleepiness, cataplexy, or potentially disturbed nocturnal sleep, or one of the other pentad symptoms that an individual may have. Phase 4 studies generally are after there's FDA approval and is looking at real world evidence or post marketing analysis of, are there other side effects that maybe we didn't recognize or didn't come to light? And after 5 years on the drug, there's something else that we need to inform our patient population and our providers about.
This is so exciting. And just feel so grateful and hopeful that there are so many, new options possibly coming down the road for people with narcolepsy. And I know patience is not my strong suit. I always say I'm the most impatient patient. And so it's hard to sometimes think, well, is this days? Is this weeks? Is this months? Is this years? Is this decades? But I think, by laying out this process and also just like explaining how well studied each of these treatments, hopefully, if they go through the full process to approval and then even more study after that, that there's so much care to develop each one. It really gives you a lot of respect for such a big, rigorous process.
And I think one of the other pieces that is so important is that when there's pharmaceutical companies who are looking at some of these targets and developing these drugs, they don't go it alone. One of the things I've been repeatedly impressed by is that they will seek out expert opinion to be able to help in better understanding, is this the right study design? Are we looking at the right outcomes? Are we looking at the right patient population? And you're 100% correct in that it's not, unfortunately, something that can happen overnight, but that's for safety reasons. And so I do think that it's incredible that there are so many different companies that are developing treatment that are going to be extremely meaningful. And when you highlight the fact that this brings hope, I do think that that's so important. Many times when I'm giving talks about narcolepsy, I very frequently will make the analogy to another neuroimmunologic condition in neurology, which is multiple sclerosis. And the reason I make that analogy is because there's so many similarities. The prevalence of the disease. So we talk about the worldwide prevalence of narcolepsy being 1 in 2,000. The same exact thing is true for multiple sclerosis. They're both considered neuroimmunologic processes. And the final piece that I like to highlight in regards to hope is that when I was training in neurology, there were really two main lines of therapy. You now look at the treatment landscape for multiple sclerosis, and there's about 30 different treatments available. I think narcolepsy is on the same trajectory. And when I look at the impact it has had on patients with multiple sclerosis in terms of socioeconomic disability, quality of life, functionality, it's been transformative. And I feel so, so privileged to be practicing in a time where I truly believe that that same type of transformative care is on the horizon.
Oh, I love that. Okay, I'm going to try not to cry. And usually it's more storytelling that gets me crying, but that was really beautifully said. I just wanted to take a second to emphasize that, as we talk about these new options, they can't come to market without people with narcolepsy at some point being part of that process. And so we're really thankful to all the people with narcolepsy that have been participating in clinical trials and clinical research. It's really amazing. So I just wanted to point out some of the reasons that people do decide to participate in clinical trials. It's really like being part of history sometimes, and helping to contribute to science moving forward. You also are doing something to support a broader narcolepsy community. Many of the clinical trials are happening in the US and Europe. And so they're not even available for people in other parts of the world to be even a participant. So for those of us that are in places where these clinical trials are available, it's really supporting the broader community And also, you do get the possible opportunities to try novel treatments and to, receive expert care from research staff. And I just wanted to say, from talking to people that have been on clinical trials, they actually get to really learn more about their own experience with narcolepsy. They're often doing many surveys and all sorts of different things. And it can be very educational to understanding one's own experience. And so I just wanted to mention that because, again, often I've seen that not necessarily, I don't know about in the narcolepsy space, but more broadly with clinical trials, they are often slowed down because of trying to recruit people to participate, so it's really, really important for people to be willing to step up and participate. I don't know if there's anything else you wanted to add there, Anne Marie.
I think you're right. I think there's sometimes people are unaware of the fact that there's clinical research opportunities, and they don't necessarily need to be occurring in the office that you're seeing your sleep provider. And so there is many times that companies who are doing these clinical trials will have different posts on social media trying to just improve awareness. There's also the opportunity of going through something like clinicaltrials.gov, where you're able to put in a disease state and it will give you some ideas. Oh, I did some nice foreshadowing. You can actually put in a disease state and it'll give you some different options. And again, because there's different phases of it, it may have different participation criteria or different lengths of obligation. Sometimes there is involvement of blood draws and sleep studies and things like that. And I do think that when looking at the participation in clinical trials, there is very frequently a sense of how will this help me? But I think many patients, especially those who have rare disease, think, how is this going to help the bigger community in general? So I think that when you are looking at different opportunities for clinical trials, you're 100% correct, Julie. We usually have very large teams that are working with our patients to ensure that all of their questions are answered. And that's in addition to the pharmaceutical company and research teams that they have there.
Yeah, perfect segue. So, if you want to learn more about the different opportunities, yeah, sometimes they're posted on social media through their own ways, but also on nonprofits like Project Sleep or Wake Up Narcolepsy Network. Hypersomnia Foundation often will share announcements as well about clinical trials. So, we do highlight some research projects on our website, including some that aren't even clinical trials. It's like currently we have one, a pediatric survey through Children's Hospital in Boston. It's a great opportunity. So there are even some things you can just complete a survey or do an interview and really help the research process as well. And then the map from clinical trials, I put in narcolepsy and currently recruiting. So there are, supposedly 14 currently recruiting in the US, 7 in Europe, and 1 recruiting in Australia and Canada. So, but you can put in narcolepsy or idiopathic hypersomnia into clinicaltrials.gov. And it's kind of interesting to see too, some of the different stuff that's happening. Just wanted to segue a little bit to some other aspects of caring for narcolepsy, because we do have the medical management, but also remembering, as Dr. Morris said, that looking at the whole picture. So I like this quote from my own presentation back in 2015. We may not have a cure for the condition today, but we do have a cure for the loneliness, which is social support and being part of this community. And so, just these reminders about some of the non-pharmacological approaches, naps, and kind of even thinking about medications. If we think of sometimes that the goal is to get rid of the nap with medications, then I think originally I thought that if my medications were working well, I wouldn't have to nap. And I've still found that I do have benefits from my treatments, but napping has continued to stay an important part of my treatment as well. But social support has been absolutely huge for me, and I know for a lot of other people. And so just emphasizing that is always important, especially when I'm talking to doctors and healthcare professionals who may be thinking more about the medication, rightfully so, because that's what they're really empowered to help with. But also letting them know about the importance of connecting people to organizations like this so that they can get more support for the social side, and knowing that they are not alone with all of these struggles. So, just want to mention those important things. And for me, therapy was really important to process. Not that because, I needed to it was just dealing with a chronic condition. I think that it should be more it should be normalized in our society that if you're taking on, a major life-changing thing like a chronic disease diagnosis, that talking to someone on a regular basis can be helpful. I kind of happened upon that for the first few years, which is really helpful.
I just wanted to comment on that. I want people to actually hear what you just said, is that being an individual who gets diagnosed with any chronic disease, including narcolepsy, it is okay to seek out support because you have experienced something that is transformative to your life. And no one is born in this world completely equipped for something that just completely changes what their expectations are. And I think that the fact that you had that realization and ability to seek out someone to help you with augmenting your coping skills and how to navigate and how to be productive obviously clearly has been demonstrated by your tremendous success in Project Sleep. But I do think it's something that is so important for people to hear because, again, I think that some people, when that suggestion is made of seek out a psychologist or a counselor to help, that we're saying that you're depressed because you have this condition. And that's not what we're saying. It's saying we want you to be your best you.
So thank you, but I actually didn't. That's not what happened. So what happened for me is that before I found the terms narcolepsy with cataplexy, like the week before, the primary care doctor had suggested depression. I didn't feel depressed. I felt tired, but I did feel out of control. And I was willing to try anything. So I went to a therapist 1 week. And then I found the word cataplexy, which led me to narcolepsy. And I forgot to cancel the next appointment with the therapist. And so I was like, oh, well, I'll just go. And so I went and I just told her about, oh my God, I found this term and this is what it is. And I was like, oh, hey, I kind of like talking to you. So I actually call it sort of, I don't think that I would have gotten the diagnosis and then thought I deserved it, but I kept her for the next 2 years. And my therapist was just so essential to helping me even thinking about changing my career a little bit away from being a lawyer to writing a book. And it's been a huge part of my journey, but that's not what happened. I didn't seek it out that way. I call it like kind of like the best strange error that happened in my process of, finding narcolepsy that ended up benefiting me. So hoping that we can do better for other people and that they don't have to go about it that way. But looking back, it's just amazing that I had her at that point in my journey for those 2 years of getting through law school with narcolepsy. So yeah, it is kind of strange. And I think there are some therapists now that are having like a chronic illness specialty, which is really exciting. There's a small list on Lauren Sheffield's website or Selfridge. I forget her name exactly, but she's a therapist in San Francisco who has MS and a podcast. And we will make sure to put that in our resources. So lifestyle adjustments, there's a lot of other things that people do because people are often so proactive in trying to feel better and maybe don't get the benefits that they're hoping just from treatment medication. So Anne-Marie, is there anything you want to share? I know that you've done a lot of work in the area of trying to help people in other ways.
First of all, I think these are all so critically important. I don't think it's just kind of taking one and running with it. I really do think that empowering a patient to be able to utilize all of these different options to maximize their day-to-day function and quality of life is critically important. When looking at lifestyle adjustments for every single patient that we see, we're always looking at sleep habits and making sure that they have optimal sleep hygiene, that they're entering in good bedtime routines so that they have a healthy association with that. We also look a lot at diet and fitness. And the reason why we look at that is because there is normal biologic changes that are occurring with optimal diet and fitness. When we're exercising, a lot of people will refer to those endorphins that are kind of being activated. And those are wake promoting neurochemicals that are making you have a much more natural development of being able to be awake and engaged, et cetera. When you're talking about diet, there is some suggestion that different types of diets may contribute to improved wakefulness and decreased likelihood of lapsing into these kind of sleep attacks or that sleep inertia that really drags many people down, even those who don't have narcolepsy. Very frequently, people will describe after they eat a big meal that then they feel very sleepy. Well, that is a very common thing. When we look at the different types of foods and what the diets can consist of, there is some suggestion that low carbohydrate or even ketogenic type diets may provide some benefit in terms of wake promotion and improvement in sleep. So myself as a neurologist, I can say that there's lots of data about ketogenic diet in the world of seizure disorders. And many times we're using that for seizure management. But one of the fallouts that we've identified is that many patients who take ketogenic diet, we also see have this benefit in their sleep. Well, I think that's not by accident. It's very much by design. Because when we're looking at the individuals who are on ketogenic diet, which if you consider this, please do so with a registered dietitian and someone who's very familiar and making sure you enter it safely. We are generally achieving a goal where a person is producing ketones. So basically, it's a different energy source than regular carbohydrates for your brain and your body. The specific ketone that we usually are measuring is something called beta hydroxybutyrate. So when we talked about those oxybate therapies earlier, the active metabolite that we're looking at for there is gamma hydroxybutyrate. If I were to hold a mirror up to gamma hydroxybutyrate, I would be seeing beta hydroxybutyrate. So it is an isomer, a mirror image of it. And so when we're looking at that, I do think that the reason we're seeing this potentiation and improved wakefulness and good quality sleep is likely because of the fact that it's exerting similar effects of what we see with gamma hydroxybutyrate. So there are some clinical case reports that have been described of utilizing ketogenic diet in narcolepsy, and some report that there may be benefit. But in terms of large randomized controlled trials or large case series, we're really lacking that kind of data.
Thank you so much for talking about that, though, because I think even with social support, as Dr. Morse knows, I'm a big proponent of social support. And I have had some doctors say to me something like, well, it hasn't been proven that that's going to improve someone's outcomes. But I also don't think that there have traditionally been a lot of incentives to do big trials to look at whether. So just because there isn't the data, robust data today to support some of these approaches, it doesn't mean that they couldn't be effective for a lot of people or for some segments of people. And so it's just really, really important. I always like to mention, I'll just say, I have heard, I talk to a lot of people and parents of younger people with narcolepsy. And one instance always stuck out to me, though, where a child had been newly diagnosed and still was having severe cataplexy. And the parent seemed afraid of traditional medications, of, pharmacological treatments. And so I just remember this mother saying, I just trying to get him in with a trainer 3 times a week. And that was going to be like, yeah. And that really scared me. And I just thought that it's always important to remember that these can be great additions, but often getting their medical management in better line somewhat first. It should be probably a first priority, at least in that example. So just, just always want to mention that. And that usually if anyone says they found like a cure, that it's going to do everything, it makes me a little bit skeptical. I'm much more interested when people say, well, here are some of the benefits, but usually I haven't found anything that's been a full-on like cure for narcolepsy, but these are so important. So
I think the points that you make in regards to support groups and really peer support in general can be very critical. And I think that when looking at this, I also think some of the work that Project Sleep has done, like the Rising Voices of Narcolepsy, should also be considered a part of that, because even though that is a program that is dedicated to helping people be able to speak more on their condition, I think it is a significant role for empowering people to feel more in control of the life that they're living by just being able to communicate with others very effectively about the journey that they're having. And so I do think that there's so many tools that have been made available through Project Sleep and many other advocacy programs that do help in going this journey and not feeling alone.
Thank you. We agree. We'll probably have data someday to talk about how empowering it is. But definitely has been a big part of my journey, which is what has landed me right here. I just wanted to close with a few beautiful poems because, we always love our different ways of expressing things and different quotes. And so this is from Amanda, who's in Scotland. Her Instagram is My Sleepy Stories. And she had posted this the other day, and it just is unforgettable and resonated with me, this first stanza of a longer poem. But she says here, take these twice a day. They'll keep you wide awake. You'll focus on everything trivial. They'll wonder what's wrong with your face. And I guess she writes in the post where she shared this, and I did ask her permission to share this today, but on her posts on Instagram, this was, about her experience with one of the wake promoting treatments. I just thought you'll focus on everything trivial. Really resonated with some of the challenges of managing some of those stimulant or wake promoting treatments and feeling awake, but maybe not able to even focus on the right things. It just really was a powerful line there. And another poem by our esteemed poet laureate, I'd say Project Sleep's poet laureate and board member, Anna Lara wrote this poem, and I just wanted to share it with you today. To buy myself time with my eyes open wide, I medicate in hopes to freeze time and extend my daylight. I buy off the shelf what I can't make myself. Is this script made for me? Perhaps, we shall see. I'm feeling it now, freedom each time. When I take the pill, it's like I can fly. Damn it, I'm crying. The fog has dissolved. My icy skin thawed. To feel this sunshine brings tears to my eyes. Is this what it's like to be alive? Such a beautiful poem, and just reminds me of why we're trying to do this, and so that more people can have more moments like this of being alive. Okay, sorry. But thank you, Anna, for your beautiful words and for letting us share them today. And Amanda. Just a reminder, of course, about the different patient organizations that are out there. Project Sleep is one of them, but Hypersomnia Foundation, Narcolepsy Network, and Wake Up Narcolepsy are three of the other ones here in the United States. And there is an incredible group of organizations around the world as well. And please visit our World Narcolepsy Day webpage, where we've outlined 20, I forget if it's 26, 29, I don't know. We have a lot of different partner groups around the world now. It's pretty awesome. Please connect to these organizations for more information and education and resources. And if you if you want to learn more about participating in research, check out our webpage, check out clinicaltrials.gov. We did mention that AASM did just put out really recently in September new clinical practice guidelines for hypersomnia and narcolepsy. So that's a really exciting resource that I believe yesterday I checked and that you can download the paper for free, the PDF. So that's nice when there's not a paywall keeping this information from us. So we'll make sure this is in our toolkit. And just really want to mention Anne-Marie's website. Can you describe a little bit about Wake Up and Learn?
Sure. So Wake Up and Learn is actually a school-based sleep education and surveillance program that we developed that is free of charge for schools to participate in. And the goal of it is really to try and break down that barrier between people who are suffering from sleep disorders, including narcolepsy, to appropriate time of diagnosis and treatment. So what we have done is sleep screening in the school systems, so that this way the student meeting the students where they are most of the time, rather than making them leave the school to have to come to the doctor's office, and allowing us to really provide universal education to all the key stakeholders in children's lives. We are very excited because we are planning to try and get additional grant funding to expand the program. So this way we can also not only meet our middle school and high schoolers, but also college, medical school, and resident physicians. So that this way we're further augmenting the awareness and ability to diagnose and get people appropriate treatment. Really, the goal is to empower people and recognize the importance of sleep and the role in our overall wellness.
Amazing. We'll have to have you back for another podcast about some of that. That's so, so cool. Thank you for all your work. So in addition to being, you just have so many hats you're wearing. And this is just one of them, and the right person for the job.
Thank you.
So, and just a reminder, of course, please sign up for our e-updates to get announcements about the Nerd Alert series. In particular, we will have a toolkit based on this discussion today. Thank you, everyone, for tuning in, and huge thanks to Dr. Morse for generously giving us this time for education and awareness and community. It's just, you're a huge part of my journey in this community, and really lucky to work with you in different ways, and especially today.
Thank you so much. I appreciate the opportunity to be a part of it.
The Project Sleep podcast is produced by Carver Sound Productions. For more information on podcast production services, visit carversoundproductions.com.